Okay, so we will start with this webinar. We have called it the wide world of knee osteotomy, in the way that we are used to see osteotomy books and articles and even symposiums focus on knee osteoarthritis mainly, osteoarthritic varus or valgus, and we want to show in a case presentation based webinar that the different options, that the osteotomy is much more than that, that it can be used for many different circumstances and different clinical cases, not only for tibiofemoral, but also for patellofemoral diseases. So we will see here, and I think with a case presentation format is more practical. And the idea is we have 4 different surgeons, from 2 from Europe and 2 from the States, and we in a second we will introduce each other. And the idea is to present the case, and then I just flip the coin, and we already have an order to ask the rest of the speakers. And of course, if you can have if you want to make a question or a request or something like that on the YouTube channel, you also can do it, and we will try to use it as a source of discussion. So first, Seth, can you start introducing yourself?
Yeah, hi everybody. Thanks, Pablo, for having me here. I'm Seth Sherman. I'm associate professor at Stanford University in California, and just very excited to be a part of this on a cheery Saturday morning in sunny California.
Gonzalo?
Hello, everybody. Thanks, Pablo, for your kind invitation. I'm really honored to have this group, because I know the work of all of you. I follow your papers, so I'm really happy to be in this group. I work in Barcelona. I work now at the Instituto Cugat in Hospital Quirón Salud, Barcelona. And I mainly focus in knee preservation surgery, but I also do shoulder surgery, and that's sports injuries, and that's my practice.
Excellent. And Alan Getgood.
Hey, Pablo, thanks very much for the invitation. Great to join you guys this morning here in Canada. So I'm Al Getgood. I'm associate professor at University of Western Ontario, London, Canada, and work at the Fowler Kennedy Sport Medicine Clinic. And yeah, it's great to join you. I imagine you guys will log out of sunshine. We actually woke up this morning to snow in early May, so interesting times. But good to be here, and looking forward to the next hour. Cheers.
Excellent. Thank you so much. Well, I'm Dr Gelber. I work here in Barcelona, associate professor at the University Autónoma of Barcelona, and I'm fully dedicated to knee surgery. So now we will start with the Alan case. Can you share your screen, please, Alan?
Sure.
Okay. All right. So Pablo asked me to present something a little bit different than the normal osteotomy case, so I thought we'd go for hyperextension recurvatum, so not so fantastic based on our fantastic 4 picture. So some of my disclosures not really relevant for this particular presentation. So I'm going to present this lady. She's a 61-year-old lady who presented to me in clinic just sort of the middle part of last year, and her history goes back to when she was 15 years old. She had a proximal tibial corrective osteotomy, or at least that's what we think had happened. We don't really know the exact details of what she had done. Needless to say, there was some metalwork still in situ, but you'll see from her radiographs in a minute as to what's going on. But she actually presented initially to one of my colleagues who does knee arthroplasty, because she was complaining of really quite significant pain following a fall 1 year previously. But up until that fall, she'd been managing relatively well with some degree of knee laxity with a hyperextension thrust. And so she'd been coping with this for quite some time, but the fall 1 year previous had really increased her pain. She was really struggling to cope, and she was referred for a family doctor for a total knee arthroplasty. But my arthroplasty colleagues weren't that keen on doing a knee replacement. She's otherwise healthy. She's a non-smoker, so really no comorbidities to think of. So I'll just give you a look at her clinical exam. So you can see on the left-hand side, you can probably hopefully appreciate significant hyperextension and then in her degree of flexion. So maybe just looking at those pictures, I'll go to Gonzalo first. Any comments when you just see a sort of a clinical presentation in this manner?
Also, it looked like some hypertrophy in the muscle in that knee, probably shorter than the other knee, and I can see there's some posterior sac maybe. So I don't know if they try to correct some kind of posterior instability with that high tibial osteotomy, or kind of.
It's hard to know. I'll just give you sort of a dynamic video of her.
Yeah.
So I can see there is no much instability.
Yeah, so her main instability is really the hyperextension thrust.
Yeah.
Okay, but in terms of her laxity pattern, she's got a little bit of laxity both medial and laterally, and varus valgus stress. She does have a posterior drawer, but a really solid endpoint, and then you can't really reduce her knee forward. Seth, any thoughts on that in terms of then what you'd be doing from maybe an imaging point next?
Yeah, I would just make the point that, symmetry of evaluation. So looking at the opposite limb and gauging her native laxity, to determine pathologic versus native, and then, making a problem list here, for these cases. In all cases, we're getting standard radiographs, obviously. So weight bearing AP, PA flexion, lateral merchant. I'll start with a mechanical axis view. And then likely we'll, given her previous osteotomy, I mean, we're looking at some rotational type analysis and, sagittal plane analysis.
So here's her AP and her flex view, so her 45-degree flexion view or Rosenberg view. So I mean, a lot of time we'll see maybe images like this, and you think, wow, this, and I think maybe she was. Well, maybe, would you make a comment on that radiograph?
So this is weight bearing, Al?
These are weight bearing, yeah.
Yeah, I mean, so there's, potentially in that sagittal plane, if she's, posteriorized, there's that overlap. So I don't know if that's static or if that's dynamic. And
right. And I think this is where maybe our family doctor fell into a bit of a trap in some ways, and that looking at the radiograph thought it was bone on bone OA, needs a total knee replacement. Whereas actually this is just an issue of deformity in the joint, and really not so much an issue of joint space loss. So there's her right compared to her left. And Pablo, what do you think of that when you see her lateral?
It's amazing. I will also we need to have an MRI to see how the condyle articular cartilage is, of course. But in case it is, you can save the knee much more desirable with this, tibial slope, which is around, I don't know, 20 degrees to anterior slope, something like that. It's amazing. It's pretty nice, and you see it is clearly seen that the deformity is extra-articular there, just about 6 or 7 centimeters. The core is below the joint line, so that would be a perfect case. After seeing carefully the MRI, because if the joint is totally destroyed, I will also go for a total knee. But if there is something to solve, and I will go for something to correct this anterior tibial slope.
Al, can you pin down for everybody just how you measure slope on the lateral? Because it's going to come up in my case too. We might as well start that conversation. What's the easy way, or is this not the best measurement?
In the presentation mode, it's a bit difficult to actually show the measurement, but the way I tend to do it is draw 2 circles. So one at about 6 centimeters, one at 15 centimeters distal to the joint line, and then draw a line through the center of those circles, which essentially denotes the mechanical axis, and then draw a line off of that along the parallel to the slope. And then you're trying to determine which is the medial, which is lateral. You can see here, this is the medial slope here, then the lateral slope's a little bit lower. So again, it's not coplanar. But I would just draw a line in between those. I would argue that the absolute number when you're looking at a deformity like this is pretty immaterial, really. I mean, it's pretty obvious that it's incorrect. And, the question then comes is, what are you going to do about it? She's also got some degree of valgus. with a deformity. And it's really hard to know exactly what happened when she was 15 years old, whether or not this was a fracture fixed with K-wires or whatever. But if it was, then we're presuming that she had some form of growth arrest at the level of her tuberosity, and hence she got this issue with her reverse slope. So the big question then is, what do you do, Gonzalo? So there's the total knee well, one thing is you could say, well, there's nothing. I mean, would you offer this lady surgery, or would you just say, you know what, you've put up with it since you were 15, suck it up and live with it?
Well, if she's going to us, it's because she's really struggling with this knee, so she probably is asking for something to be done. I'm not a knee replacement guy, so I always do my best to avoid knee replacement. I think there is still a chance. Of course, that's an option, but there is a chance to save the limb without doing a replacement. So I think I know where we're going. We're going to an osteotomy. And my concern will be try to correct that hyperextension. So the tibia is posterior subluxated. So we have to correct the slope. We have to correct the posterior displacement of the tibia, and also we have to try to correct the shortening. And I guess we can do that with one of the osteotomies that now is very common in the anterior tibial osteotomy, where we are correcting all these deformities. We're putting our opening, it would be in the front of the tibia. And that would be an option just to save if that fails, then we have the knee replacement as a backup.
It's also fair to comment that a total knee here is not an easy case too. It's very aggressive also, because you have to perform really huge cuts to fit any kind of prosthesis. Even more here, you need to go at least with a LCCK, so a semi-constrained model. So even though that even the osteotomy would perhaps this patient will end up in any case with a total knee, but we can give her an option to perform the osteotomy where you restore somehow the normal tibial anatomy, and perhaps in a second stage, a few years, some years later, that you can think in a replacement. But I will give her a chance. Again, seeing first the MRI. I want to see here if there's something to keep to maintain regarding the articular cartilage. But then with you osteotomize the tibial tuberosity, and then it's not that complicated technically. Then you can fix it with staples, with plates, whatever you want.
I would just add briefly, I would maximize, conservative treatment. Going into a big surgery, you want to make sure that they know that they have no other good options and they need surgery. So I imagine that clearly was done. If she had instability but not pain, which is not this patient, then perhaps, trying bracing, etc., might be reasonable to get her through. That's not the case. She has debilitating pain and deformity. I don't think she has any options other than what you guys, are about to plan. I would opt for deformity correction. I think that would be a very hard total joint as well, although I do not, do those routinely anymore.
Okay, we'll move forward, Al.
I took her to a case conference to discuss it with the arthroplasty guys, because there was no question that doing a joint replacement was an option on the table, but probably would require some degree of constraint, significant bone loss. And the interesting thing probably bring up about the MRI, our thought process here was, even if there was articular cartilage wear, if we got her back into a more kinematically improved position, and she still needed a total knee 2 years down the line, it would still provide a position for her to have a primary knee as opposed to some sort of more constrained joint. So I'll just run through as to what I did. So the operative procedure was, we're planning for a proximal tibial osteotomy. So it's an anterior midline incision. We elevate tibialis anterior as well as the MCL, and then we do a tibial tubercle osteotomy. Pablo, when you do this type of case, do you take the tubercle off, or do you tend to go super tubercle, infratubercle? What's your thoughts on that?
Absolutely, I take the tubercle off. I don't hesitate to do that. There's no risk of non-union or something like that. I want to work comfortably with a good exposure, and no doubt. From my point of view, no doubt about that. What do you suggest?
Yeah, so I think if you're if you go super tubercle, you're going to create significant patella baja. If you go in for tubercle with an opening wedge, your risk there is that you're going to end up with a very anterior spike. I think if you do go in for tubercle, you could use a frame and then correct it gradually, maybe an option. But then you've got the issues associated with framing. So I tend to do a tubercle osteotomy, then it's much easier exposure. And I'll show you what we did. So this is just taking down the tib ant and then taking a cob underneath the MCL on the medial side. Then did the tubercle osteotomy. The challenge here is that she's got a very small tubercle. It's not a very prominent tubercle. So we ended up with quite a thin shingle of bone. But of course, we're doing that under saline irrigation the whole time, just to try and reduce the risk of bone necrosis, thermal necrosis. Then insert the guide pin under fluoroscopic guidance, really aiming for positions sort of just distal to the PCL. And that pin's in a good position because I'm going to go with my saw distal to that pin. So it's going to come down to that sort of champagne glass drop off region. And then starting with a oscillating saw, finishing off on the right hand side with an osteotome again under fluoroscopic guidance, and then gradually open it up. And I've used 2 laminar spreaders. And if you saw on the hip to ankle films initially, she had a degree of valgus. So I'm actually opening up a little bit more laterally than medially, again, to try and build in a little bit of correction in the coronal as well as the sagittal plane. And then the question comes as to how much correction do you do? And I really just dial that in to the degree of hyperextension that you can correct, because the last thing you want to do is create any flexion deformity. So I was able just to dial this in over the course of the correction, aiming preoperatively for about a 20 millimeter correction. So it's not an insignificant correction. And then took a femoral head wedge, and then you can basically cut 2 separate wedges. Take one laminar spreader out, put one in, take the other laminar spreader out, put the other in. That gives you your correction. And then I had to put a further wedge to build out the front so I could put the tubercle back on, and then fix that with 2 screws, one proximal in the metaphysis, one in the distal metaphysis. So that essentially gives you your deformity correction. But of course, now you just need to stabilize it. I think, Pablo, you had mentioned that you would use you can use a staple or a plate. What would your, Gonzalo, what would your preference be for fixation here, just to give the stability?
So I'm more familiarized with putting like a lateral plate, medial plate, I don't really love to work in the lateral side for tibial osteotomy. In this case, you need a lot of stability. I will go first for medial, but I would consider to have in my table a lateral, maybe a smaller plate or something else, just in case it's not stable enough or it's opening on the lateral side.
Seth?
My biggest concern, I'm sorry, go ahead.
No, I mean, this is a huge correction. It's opening. You know, I like the bone grafting that you did, so that adds stability, but I'd considered, dual plating in addition to fixation of your tubercle.
Yeah, my one concern is stability. The second concern here is healing. You have such a huge allograft right there that I really will have my doubts about incorporation, real healing, because the creeping substitution only happen with around 10 millimeter of the bone. So here you have a huge, almost 1/3 of a femoral head. But I mean, I'm not criticizing at all. But the problem is that you have the answer because this is your patient, and you can show us how it went.
Well, I think your point is really important, because if you put in a fixation device that's not going to be able to maintain structural stability for a long period of time whilst this bone graft is incorporating, then you run into the problem of it losing correction and really having a major issue. So, and particularly it's in someone at the age of 61, I was a little bit concerned about this. So normally I would just fix these with either in a really young patient, particularly with a smaller correction, just 2 staples. But for this, we did basically a lateral and a medial plating to give it really both the medial and lateral pillars really good stability. So it's a bit of a metal sandwich, but it really just gives that strength. And then you can see she has got some joint space narrowing on the medial side, but she's actually doing remarkably well. That's her final correction. So you can see actually get just in the static phase, you get her tibial station much better. And certainly she had no hyperextension anymore after we'd finished the case. That's her 6 months post-op, healing nicely. She's got normal straight leg raise. I haven't seen her back in the last 3 months because of the lockdown, but she's doing very well. She's walking around her house with no pain and a cane. So
you dial in her tubercle based on intraoperative lateral X-ray, lateral fluoro?
Yeah, I mean, I just basically moved it up and kept it with the level of her metaphysis, but you can just change the position of it. So it's really the metaphysis that's allowed to go with the metaphysis, so to speak.
So in this case, you proximalize it a bit to prevent BA.
Absolutely.
Go ahead.
Go.
So that's me. Any questions?
Okay.
Yeah, which is beautiful is how the tibia corrected. It was so posteriorly displaced and now it's centralized. That helps a lot for this kind of deformities, posterior sac, but also for anterior fixed deformities. It's useful to do the opposite when you're doing an osteotomy. And regarding the comment that Pablo, he said that he was concerned about healing. Of course, this case is special. It's very unique. But we're used to put like an allograft. We asked for a proximal tibia allograft to do our osteotomy. So we put an allograft for any correction. And what I saw is because of the compression that the own tibia is doing over the allograft, they heal very, very fast. And also you have immediate support for the postoperative period. So I would be concerned for healing because of the big exposure and the kind of patients, but not as much as because of the bone allograft used. Yeah, I think one of the major one person's got a lot of experience in this area is Ron Van Heerwaarden, and I spoke to Ron. I've done a number of these cases now with this sort of level of correction, and he's never been concerned about. He has concern, but it feels that these heal without too much trouble. Even up to a 20 millimeter correction, so that's not as big a concern. But there we go.
Great.
Thank you, guys.
Okay.
Thanks for
Very nice.
Thank you so much. Very, very nice case. We will move forward to the second one, which will be presented by Gonzalo. So Gonzalo, all for you.
Mine, I think, is very straightforward, but still, it kept me thinking. So, am I starting already? Yeah. Good. Are you seeing the presentation now? Is it okay?
Yes, go ahead.
That last case wasn't straightforward?
Yeah? Well, I think it's going to be easy for you guys. But still, it kept me thinking for a while, several nights. So that was a 56 years old woman. She had a previous left knee osteotomy. It was a distal lateral wedge opening, distal femoral osteotomy. It was done 10 months ago outside in an outside facility. I was not the surgeon who received this patient at first in the clinic, so it was presented in a clinical session that we were doing in the morning. At the time, I was in a public hospital. So the patient was complaining about persistent, mechanic, non-localized pain. It was not very specific, with wet varying, some discomfort. She had some weakness, but I don't remember that she was not needing crutches. She was very upset. She was not happy, but she can kind of move around. She was able to move around. In the physical exam, when I examined this patient, when I took charge of this patient, there was no effusion. There was a diffuse lateral and patellofemoral pain, and the knee was stable, and the range of motion was quite decent. Maybe it was limited because of the pain after forcing for more than 100, 110 degrees, but it was kind of almost normal. But there was a visible misalignment and varus thrust when she was walking. So I'm going to show you the first X-ray. So that's the first imaging I'm going to give you. And I know it's not too much information, but I would like to know what are you thinking. I don't know who's the first in line. Probably have the line, or maybe if you want to comment on this X-ray.
Well, just my first impression is that it's a problem of healing here. I don't see that there is a union. I think there's a non-union of the osteotomy.
She's walking without crutches for several months already, but she's not comfortable. So do you think if at this point, because that was the concern for all of us in the session, is it healed? Is it not healed? But my thinking was, well, she's walking. This plate is not very rigid. It's not very stiff. If this is a real non-union, that plate it would be probably broke. But I agree that we're not completely sure. I must confess that I asked for a CT scan, and there was some breaches some bone bridges that demonstrate that it may be healed, but I was not sure at all until later.
Gonzalo, did you have any access to serial films, like from post-op, to see if there's been any change in correction?
No, not really, not much. I didn't have the report from the surgery. So the patient normally, you know, that they normally don't know exactly what was done for them and why sometimes. And that was the long-standing X-ray that I'm sure all of you.
The problem here is also that the osteotomy broke the medial cortex, so it overcorrected the needs. It's really it's a 5 or more than 5 degrees of value.
What do you think, Alan? Any other comment?
Yeah, I think for sure the medial hinge is gone. I definitely want to exclude infection. You got to do an infection workup. Yeah. I think sometimes when you see these this type of hardware, radiographically they can look normal, and when you get in to take them out, actually the screws may have broken. So you got to be aware of that as well. And it nearly even looks like there's only 2 screws distally, but maybe that's not the case. But in any case, it could be sort of essentially a hypertrophic non-union where there's actually too much mobility or it's infected. So for sure, infection screen, CT scan, and then look to revise.
Yeah, so we did the infection screen. It was normal. PCR was normal. She was asymptomatic. There was no redness, no symptoms locally. I know it doesn't rule out completely the infection, but the analytics was normal. The CT, I don't have the CT. That's as much as I can give you about the CT. I couldn't recover the CT because I changed my practice. As you know, I was in Madrid like a year ago, and then I moved to Barcelona, so I don't have access to the CT.
Yeah, we know this. People in Madrid is not fond of people in Barcelona, so they didn't give you the X-ray.
we don't have connected systems, so that was presented, as I said, in the clinical session. So the diagnosis, you already said it. To me, it was a medial hinge fracture, and maybe because of the early weight bearing, because of the stiffness of the plate, because of the delayed union, whatever the reason, there was probably medial hinge fracture from the very beginning, probably, and at some point,
Gonzalo, before
yes.
we talk about what to do at this point, which is more challenging, if you're doing an opening wedge DFO and you see that intraoperatively, can I ask you guys what you would do at the time of that initial surgery?
Yes.
If I'm using this kind of plate, I will plate medially. If I'm using a locking plate, perhaps depending on the weight of the patient and all the stuff, with a locking plate, perhaps I would just keep it in a way. It depends if it displays lateral, medial and laterally, but if it sits in place and with a small medial hinge break, I will keep it in that way. With this plate, absolutely, you have to plate it
switch
medially.
or change. Yeah.
The problem sometimes is you don't realize that you broke that cortical. Many times it's like non-displaced, and you realize over time when you follow the patient, and that has been described.
I think the thing to remember, guys, is that if you're doing a medial closing wedge and you have a hinge fracture on the lateral side, that lateral hinge is going to be on the tension side when you're weight bearing. So even if you've got a locking plate, you probably still need to stabilize it. Where with a lateral opening wedge with a medial hinge that's on the compression side, I would totally agree with Pablo. If you've got a stronger locking plate fixation, then you should be okay. But if you do lose and get some translation, then fix it.
Yeah, now I must confess that that was not my case, but I had a failure like that, and I had to double plate the patient to convert the collapse. And after that, I switched to a locking plate. And the good thing with the locking plate, I'm for sure I sleep better at night. But also, even if you have a fracture of the medial hinge, you still can put that cortical, proximal to the osteotomy. You can put that screw that you can direct proximal that screw. And the technique described that gives you some compression, even if you fracture, and that's more stiff construction. And I early weight bearing much more than before when I was using the puru plate as well. So as I said, that was presented in a clinical session, and it was funny because nobody wanted to take care of the case. Everybody was like looking at the roof, looking down, about the option. All the options were discussed, like do nothing. Some people, well, if the patient is still various, but that was the goal of the osteotomy. So maybe she was just too early in the postoperative period. Let's do just a plate removal, so maybe the pain will go away just magically. And I was thinking by myself, well, I don't think that's going to be enough. Of course, we consider realignment surgery, but that's challenging surgery anyway, even if in our mind is simple, the solution, but technically it's not that simple sometimes. And of course, you always have the option to sound your pager and leave the room, so it doesn't fall here. So I finally took care of the patient, and I asked for an appointment to see her. And so, what would be your decision for treatment, Pablo? Your final decision. What did you do?
In this case, I will remove, of course, the hardware, and I will perform a reosteotomy alignment with a autograft from her iliac crest and double plate or strong plate. Is she overweighted or?
No, not really. She was a very normal patient, not overweight, and very mature. It's not the kind of patient that sometimes you have a failure with the osteotomies. Some of my failures with osteotomy, they were always single parents, living alone, not taking care a lot of themselves. Sometimes we have in the social system. Sometimes we have patients that have some economic issues, and those are the difficult one, and you have to pay attention to that aspect, because many of them, they live alone. And when I was using that puru plate, as I said, not locking plates, they're not that stiff, and you have to delay the weight bearing. And if they have to live alone, you cannot expect that they are not going to weight bear early. People who has no people around to help them out to the groceries.
Yeah, in any case, you have now a varus knee, so I probably will go for an open weight medial.
Very good. Any more suggestions? Seth?
Yeah, I think you have to work on both sides of the femur for this one. Clearly have to remove that plate. I think you have to treat this like a non-union, freshening up the site that they already were in, and then optimizing that environment for healing. So while I'm there on the lateral side, I'm going to add fixation and stability, but I don't think you can do this just from a larger lateral locking plate. I think you have to get control medially, and I would go for a neutral correction to right between the spines. So, I'm trying to think about biplanar and whether to add stability. They've already had an osteotomy line there. I'm not sure that I would do that.
Yeah, I would worry about, as you said, to me, the distal femoral osteotomy, in these cases, these challenging cases, I'm always concerned about controlling the distal fragment. You can be really in trouble if you lose that stability in both cortex, and it's not that easy to stabilize and to get good alignment in the frontal and sagittal plane. Sometimes you have to do a double approach if you lose that stability initially. So what you said is something that is very important sometimes to do a bit biplanar osteotomy to have a better rotational control. The other way, right now, as I said, the way I'm getting that initial stability in my osteotomies is putting that allograft that I pre-shape with a trapezoidal shape, so I get immediate stability, and then I can comfortably work with my plate position. And I do it in femur and tibia as well.
So what?
Let's solve the case, or?
Let's hear what Al would do.
Yeah, Alan, please.
Yeah, I'd probably try and leave. I'd take the distal screws out in the lateral plate and try and leave that plate in situ. Open up on the medial side and just realign the hinge. The question, I'd love to see pre-op or x-rays immediately after her original surgery, just to see if it was originally overcorrected. But in any case, you're gonna have to try and get the medial column out to length. I'd put a locking plate on the medial side, and then bone graft, and then also just do some simple blood work, checking vitamin D levels, pituitary function, just to make sure, PTH, just to make sure that there's adequate bone healing, or at least optimized bone healing.
How do you specifically know how much to open here? Is it an intraoperative look, or are you using any kind of planning software or any kind of specialized guides?
This is kind of challenging because I mean, you can go off of a correction, like you use the Dugdale method for a medial opening wedge. So at least it'll give you an idea as to how much you need to open up on that medial side. But I would in this case be using an alignment rod intraoperatively, which I very rarely do. But ultimately, you're really just trying to get back to a neutral position.
Yeah, I agree. It's very difficult in this case accurately, preoperatively assess or calculate how much correction you have to apply there. Also because of the lateral hinge, also it's complicated. I would do it intraoperatively. Yeah. Move forward because we are a little bit late.
Yeah, so very fast. My rationale for this, as I said, well, we normally tend to correct varus with high tibial osteotomy, but of course, in this case, there is not where the deformity is, and it could be like a remaining joint line obliquity, and definitely was not my first choice. So I was doubting in between, do it just one incision, plate removal, and a lateral closing DFO, but I was concerned about many issues, risk of shortening, maybe persistent of joint line obliquity, technical difficulties, because I don't know what I'm going to find, if like a hard, a callus, or maybe some non-union. So, and to me, closing osteotomies are more difficult to control the correction. So what I did finally, it was a double approach to remove the plate. Of course, bone grafting. I did this allograft, bone chips. And the pros for this choice, it was there was no shortening. You get like a joint line parallel, better control of the correction. And in my mind, I would minimize technical difficulties for destabilizing the osteotomy. So what I did is exactly what Alan said. I kept, let me show you the technique. I did an arthroscopy. What was sad, it was the lateral compartment was perfect. So that was sad to me to see so much trouble for a non-needed osteotomy. And she was starting to have some medial joint line problems and patellofemoral problems because of the malcorrection. So I kept the medial plate until I was sure that I was stable on the medial side, and I did a medial opening wedge osteotomy, and that was very stable. I was prepared for double plating, but that was very stable. So I removed the lateral plate and I put my allograft on the end, and I was quite stable, and the result was very good. I just centered. Once I saw the cartilage was okay, I just centered the osteotomy. So you may not see it because of the screen.
No, we can see it. We can see it.
So just short complications for distal femoral osteotomy. I think we already commented this. It was to me, it was a medial hinge fracture, possibly in a delay union, maybe early weight bearing problem, or plate rigidity of the put plate. And definitely it was a varus collapse, which is one of the complications that can happen in any osteotomy, especially in the femoral side.
That looks great. I probably would have, I might have kept a plate or changed the plate on the lateral side just to protect that. But, and then you might have to come back for harder removal again. So you get another surgery in a very complicated, course. So I think it looks awesome. Yep.
It was very stiff. It was very solid. It was rock solid. The callus that she had. It was very difficult to fracture again. It was difficult to do the opening because it was a very, very hard callus. So that's why I decided that it was okay to remove it. And I also I'm confident with the locking plate that the stability you get is much more.
Okay.
So you did great, guys.
Very nice. We move forward. Now, I am going to be straightforward, not like you, Gonzalo, but.
That's doubtful.
Exactly. Can you see the presentation now?
Yeah.
Yes.
Okay. We move a little bit up from the, well, not up to the patellofemoral to anterior. This is something I would like to know the Seth's opinion, because we all know that he's with the group you're chairing, the patellofemoral study group, Seth.
Yeah, part of the International Patellofemoral Study Group, and also done patellofemoral courses with the Learning Center. So looking forward to this, Pablo.
Yeah, whenever you want, invite me. So we have a whole entity here. Okay, so this is the group. I mean, the four fantastic. You know that I'm sorry, one had to be the girl. You're the blonde one, so I had to choose you. But in any case, this is a patient. This is a case of a patient who was 29 years old, who used to work at the office, and the only sport he used to practice was biking. And he complained of knee instability, and also he was complaining of pain and recurrent effusion. So not only instability, but he was also complaining of pain and recurrent effusion. And this was the physical examination, as you can see here, the patellofemoral tracking, and how can the patella be easily dislocated, not only in near extension, but also at 70 or 80 degrees of knee flexion. So what would you think at this point?
Yeah, so I think there's a great point when you look at instability that's not just in classic MPFL 0 to 30 that extends distally. You're thinking about patella alta, you're thinking about trochlear dysplasia. There may be also some soft tissue contractures more proximally that can be contributing, or obviously combinations with major and rotational malalignment. So this is not your run of the mill. This is a red flag.
Yeah.
The other comment, Pablo, that you brought out that's super important, not just pain with episodes, but painful effusions, maybe mechanical symptoms between instability episodes, leads me more to a comprehensive joint preservation type thought and strategy, cartilage, alignment, stability, etc.
Yeah, very, very good point you just said, because we usually split the patellofemoral disorders in pain and instability, but in some cases, a lot of instability, chronic instability cases leads to pain. So it's a mixed case. From the radiological point of view, there are many things to ask for. And the first, of course, is the standard X-rays. In the lateral view, you can see here the double contorn and the spur, which in combination will be, as David Desure classified this, the grade D, patellar dysplasia, as you can see here in the lower and right of your screen. It's a grade D. Okay, so this is the Chus view or Rosenberg view, and also
Pablo,
can I ask you,
because this comes up, how do you very easily determine B versus D? I mean, both have supratrochlear spurs. They're different severities. Maybe Al or Gonzalo also, like, is there a really easy way for the audience and for me to differentiate?
Well, are you asking me or asking Al?
Yeah, either.
Okay, well, you can see the double contour here. It's not this always. In this case, it was pretty much easy. In some cases, it's very difficult to distinguish only in lateral X-ray, to be honest. Yeah. But in this case, it was really easy to see the double contour. Mm-hmm. But at the end, I don't believe that it's much different with the treatment strategy. Because I don't think it's, at the end, you had to determine if high grade dysplasia or not, because B or D, we will propose, I think, from my point of view, the same treatment. I don't know if you think this differently.
Yeah, I mean, interesting to me with this, Seth, you got to be very careful. You get a really good lateral view. In your lateral radiograph, if there's any slight rotation and you're not perfectly aligned on the posterior condyles, you can sometimes get a double contour that maybe actually isn't a double contour. So again, you just got to be really careful. And I think this is where your 3-dimensional imaging really comes in, and your axial views, where you can get a measure of that bump. Yeah, these can be tough cases.
Mm-hmm. How would you, which radiography examination will be your preferred for determining the trochlear dysplasia?
No, I think, I mean, a perfect lateral weight-bearing X-ray is exactly what I'd use. This tells you the most about patella height, containment, and trying to get a sense of trochlear severity. So it's exactly what I would use. We'll see what your treatment is, and then get into maybe some other things I might consider. But go forward, and then we'll see where you did.
But still, no, just still many things to see, to evaluate and to assess. This was the long-standing X-ray, where you can see a 7-degree valgus knee, which correspond to the distal femoral deformity. As you can see here, the mechanical distal lateral femoral axis is 82, which when it should be around 87, 86, 88. So this deformity corresponds to the femur. as usually corresponding in valgus knee. These are some CAT scan axial views. He was complaining of bilateral instability, but the pain and infusion only in the left knee. He was complaining basically for the left knee, so we are focusing only in the left knee. You can see here the shape of the trochlea, the place where the patella is. This is, you know, TT-TC distance in high degree dysplasia is not that easy to measure. It's not, sometimes difficult to accurately decide where to place the line for the trochlea group. But in this case, it was pretty much, you know, findable the trochlea group. So it was determined around 25 at the end, you know, a high TT-TC distance, around 25, 26 millimeters. This is, we have two slides here in MRI, axial view. Here we are focusing in the patella, where you have at least a grade 4 chondral injury of the medial facet, the medial aspect of the patella. But again, you know, after having this, I wouldn't be really much sure about how the rest of the chondral tissue of the patella was. So I was prepared to have a full injury, an injury of the whole cartilage of the patella. Regarding the trochlea, you can see this plastic shape, but it was pretty much observed that it was pretty much preserved the cartilage in the trochlea. So what will you do? So at the end, we have different variables. We have the valgus, the trochlea, dysplasia, the TT-TC distance, the Npsl, and the cartilage. Professor Seth Sherman, what would you propose in this case?
Yeah, I mean, this is obviously a very extensive problem list. One thing for everybody, I mean, MRI tends to underestimate the size of these chondral defects. I mean, you clearly have half the patella that's gone, but not sure about the rest of it. Trochlea looked okay. You know, I'm probably, and personally, you know, I'm all about morbidity and risk, and I need more information. I mean, I'm probably not going to do everything in one surgery. I'm probably going to figure out how I can reliably stage this person, combining arthroscopy to get information. And I also, you know, if you need a cartilage restoration, I don't personally, you know, I'm not able to, with insurance or otherwise, order spare parts and get that part done. So inherently, by logistics, it builds in some problems. You know, I like to dance around the trochlea, not aggressively, you know, treat it. So I think you might have to fix malalignment. I tend to fix it closer to the patellofemoral joint to offload. So I'm looking probably towards tubercle osteotomy, soft tissue stabilizations, and at some point cartilage restoration, because that medial side, if you correct alignment, you're going to overload medially. I don't know that I'd attack valgus, although it's not, you know, it's a contributor to malalignment and maybe rotation. It's just big surgery, you know.
Yeah, considering that the patellar H is normal, it's a catholic index was 1, and that the dislocation was also happening at around almost 90 degrees of knee flexion, you still will consider TT transfer and Npsl?
Yeah, I mean, I think you know, that deeper flexion. I would definitely still consider it. I do worry about it. I wish there was, you know, patella alta. You know, I don't typically have experience combining trochleoplasties with cartilage restoration and other osteotomies. So, I mean, I think when you start stacking things together, it just, you know, you can add risk of stiffness, morbidity, etc. I don't think they're bad ideas. They're all on the table here. I just am trying to, you know, I'm always trying to see what the least thing I can do to affect the most change for this patient will be. For example, let's say TTO, Npsl, cartilage restoration, even MPTL, and a bumpectomy up top. I mean, I might be able to manage this patient. They're not they're not a really young kid. What do you think, Al? Help me out here.
What would you do?
Well, so I'll be looking for a little information. If you look at her hip to ankle films, she looks like she's got some rotational abnormalities, and I saw you'd written that she had 19 degrees of femoral anteversion. I'd be interested to know what's going on with her tibial torsion. I think it's often good to look at your hip to ankle films and making sure that you've got an AP at the knee. Because depending on where you work, some will just center the patella, some will look at the toes pointing forward. And if you are looking at a rotational issue, you will get some different sort of different views and different outputs. And that can make you look like it's a little bit more valgus. So I'd like to see an AP at the knee. And I wonder whether she does have external tibial torsion, in which case then this could be treated with a proximal tibial osteotomy, supratubercle, internally rotate. So that'll essentially reduce her TTTG, which of course is also elevated by virtue of the fact that she's got trochlear dysplasia. But by doing that in itself will get her centered a little better, improve her patellofemoral kinematics, and hopefully then just get her trochlea, her native trochlea, a little bit better and underneath her patella. And then I would probably just start with alignment first before thinking about, and maybe add in an Npsl to that, and then look at cartilage later. I'm always sort out the biomechanics first in these cases, and then do the biology later if it continues to be symptomatic, because I think it just gets too much.
However, you get burned on central, medial, or panpatellar or bipolar. If you put them more centralized, those tend to have less good results than offloading kind of a distal lateral with that strategy.
Yeah.
No, good. What you are commenting a very good point. From my point of view, something has to be done in the trochlea too, because otherwise the patella won't be going outside of the trochlea at 80 degrees of knee flexion. So only correcting, in any case, the tibial torsion or the TT, I don't think that it will be enough to play, because if the patella was just, this is just a comment for the people who are watching at us, that if the patella was high, with a high patella, of course you can sometimes lower the TT and engage a little bit better the patella into the distal part of the trochlea, but in this case the patella height was normal. So from my point of view, something in the trochlea had to be done to put it in place.
I think so much can be learned from a exam under anesthesia and a staging arthroscopy, and you don't burn bridges in these tough cases. You could decide to do the alignment first at that stage and come back, or you can decide just to get in, get out, make a plan, and then execute, and exactly what you're treating. Because looking at trochlea morphology matters, tracking matters under the arthroscope, cartilage mapping matters, and obviously everything Al talked about, planning out your rotations and your malalignments and then picking your poison. So.
Okay, good. So do you have any other comment, Gonzalo?
Yeah, so I will have a different approach. I think there are several ways to solve this problem. And so I know it has been described, even in this problematic, that dislocating flexion, kneecaps, some authors describe a soft tissue procedure reproducing the Npsl, the medial patellotibial ligament as well, and doing the riffing of the medial vastus. But I don't think it's going to be enough in this patient. So we have to solve the instability and we have to solve the pain. The instability, we can work on femoral side because it's pretty decent valgus. I may go for a distal femoral osteotomy in this case, which I think is easier, a very reproducible procedure. And then probably I wouldn't have to do anything in the tibia. And then once I do my femoral osteotomy, I will check how is the behavior of the kneecap. If this is still dislocating in flexion, then I will consider to add an Npsl or even a trochleoplasty if this is like heavily dislocating lateral. But if I see that there's a lot of reduction of lateral displacement of the patella just with the valgus osteotomy and it's not dislocating like below 30 degrees, I may just use the Npsl reconstruction with distal femoral osteotomy, and I will take care of the cartilage of the kneecap, but I wouldn't do anything aggressive. So what we normally do with this, if this is the case that only the medial facet is affected, which it looks like, I will go for what we are doing now, which is like doing like a MINES, like particulated bone grafting with no bone grafting, sorry, cartilage grafting. Particulated, using with PRP, we kind of do like a mesh with that, like a scaffold, and it's not aggressive. So even in the worst scenario, it doesn't work. It does not heal with the patella you always can come back and do a fresh osteochondral allograft if it fails. But I don't think it's much needed.
Okay, I move forward. The whole patellar cartilage was injured, Gonzalo. That was I was saying. Yeah, I suspected that, but in the MRI it was obvious that the medial facet, but the lateral facet also was intraoperatively observed. So I was prepared for that. So in any case, I decided to go for everything but the TT osteotomy. So I did all the rest. We will see the video here. First, I scope it. You can see the trochlear shape here, and the patella injury to the cartilage injury to the patella, and pretty much preserved the tibial-femoral compartment. I started with a big, large lateral incision, and I addressed first the distal femoral varus osteotomy, as you are observing here, as standard technique. It was the first step of the surgery to correct those 7 degrees of valgus alignment. I use a locking plate. I always use iliac crest from allograft, where I help me to do the surgery easily. More, it facilitates the technique because I place the wedges and then I plate it. And then I went for the trochleoplasty. I decided to go for the sure trochleoplasty. This is the dot line. As you see here, is the original groove, and the straight line is the groove that I was going to create. So in this case, I can lateralize the trochlear groove by 10 millimeters. So it will decrease the TTT distances without doing the tibial tuberosity osteotomy. And then I fix it with this is a Y-knot device from Comet, and I fix it then with 2 pop locks. Any company has this something similar to this. And once the trochleoplasty was done, I replaced the patellar with the patellar cartilage with a shell technique in this case, because all the cartilage was damaged. I use fresh osteochondral allograft, as you are observing here. When the injury is not that big, I always use dowel technique, of course, but in this case, the whole patella was injured, and also in order to obtain a normal shape of the patella, I replaced the whole surface. I fix it with 4 small nails, absorbable screws, and finally, I perform a Npsl reconstruction. These techniques that we have described, we don't use. We perform 3.2 millimeter conversion tunnels in the medial aspect of the patella. Then we introduce the gracilis tendon autograft, and we introduce it in the second layer, of course, and then we move, or we place the gracilis tendon around the adductor magnus tendon. We don't fix it in the femur. We just do that. We have several papers showing the benefits of this technique, and this was all we did. And with this postoperative results, stable. And this is the postoperative X-ray. It was a little bit under-corrected with 2 degrees of residual valgus, but we can see the difference here in the lateral X-ray without the double contour and the board and the spur. Different postoperative radiology. We are seeing here the CAT scan, 3D scan, 3D reconstruction, and this is the aspect of the fresh osteochondral allograft transplantation of the patella. And this is around 6 or 7 months after surgery. The surgery I performed it 1 year ago. He's expecting. We are planning to do the right knee in the upcoming months too. But I mean, I decided to do all in once. But at the end, it's a good option also to do the stages.
Yeah. I mean, that's a beautiful case. Obviously, technically incredibly executed. I agree with Gonzalo and with you that soft tissue only is never going to touch this patient. So soft tissue plus bony is critically important. I would just comment that when you start doing all of these things at different levels, including large, osteochondral allograft, I worry a lot about post-surgical stiffness. That's a big allograft. I worry about creeping substitution. I mean, this is a long-term outcome that we're going for. And I think that sometimes piecemeal or stepwise approaches are not unreasonable, or doing things like, the particulated potentially for some of these patients first before going allograft or PFJ. I mean, I think there's different ways to skin the cat philosophically.
Absolutely agree. I'm not saying this is the only solution at all, but I thought that the osteotomy has to be performed, and also the trochleoplasty. And by doing that, I just, of course, the Npsl as always, and being there. I think the pressure to control allograft is not that much, so I just added it.
Do you think that trochleoplasty offloads that patella cartilage? Because tibial tubercle osteotomy unloads and improves outcome and reduces reoperation and revision for cartilage restoration. So does trochleoplasty do the same? Do we know that?
The sure technique, this technique is specific. For example, the barrator technique, not that much, but the sure technique allows you also to reduce the patellar pressure, because
I think that's, and it improves your TTTG. So it seems rational and reasonable. What do you think, Al, for that?
Yeah, I think for sure that it's another way of unloading the patellofemoral joint. And, and I don't do it for anterior knee pain, but I know, someone like Lars Blond has, and has reported some good results. So I think, it is a good option. But, I think this case really illustrates beautifully the patellofemoral joint. There are so many issues at play when you have instability and patellofemoral problems, many different ways of correcting it. And there's still lots for us all to learn in terms of the best way about going about it, because there are often multiple procedures that it's impossible to study that in any sort of controlled manner. And I think that's a great result. And hats off to Pablo for taking on the case. Good job.
I want to see the 2-year results in a journal, Pablo.
Yeah.
Okay. Yeah. As I told you before, I had to operate on the right knee, so we can just propose what you want me to do, and so we have a prospective study.
Just one fast question, Pablo. How was behaving the patella regarding the stability when you did the DFO, the distal femoral osteotomy, before the trochleoplasty and before the Npsl? It was already stable or still dislocated? Did you check that?
Yeah.
Because I'm concerned when to stop. If I can do one procedure more, like the trochleoplasty or the Npsl, it's easy, not too much morbidity. I'm curious. Yes.
To be honest, in this specific case, I didn't test it after the osteotomy, because I really strongly believe that I had to perform also the trochleoplasty. But also one point that I forgot to tell is that this high TTTG distance is not only corrected because of the 10 millimeter of lateralization of the trochlear, but also because of the varus osteotomy, which reduced, of course, lateralize the relative the TT. But I didn't test it during surgery after the osteotomy in this case. But it would have been a good idea.
Pablo, I think Gonzalo also makes a really good point there with doing lateral distal femoral osteotomies. If you have cases of patella instability, particularly instability in flexion, you've got a very, very tight soft tissue, lateral soft tissue envelope. And by doing a lateral opening wedge, you actually increase the tightness in the lateral side and can paradoxically increase the amount of instability of your patella. So if you do a lateral distal femoral osteotomy for that scenario, you really have to do an extremely extensive lateral release.
Good point.
Absolutely. In fact, all these cases I usually do a lateral retinaculum lengthening a little bit, just to. Okay. So we move forward. Any other questions? Fine. There are some questions in YouTube, but we move forward. So now is your time, Seth?
I'm gonna share mine. If you
stop, wait, there you go.
Since we're running short on time, we'll keep this one hopefully shorter and sweeter, maybe a little bit less controversial. Pablo already showed you that he crafted me as the female member of this group, which was quite nice of him. I do have a history that I learned cross-dressing, so that's fascinating. I'm throwing it out for everybody. But I wonder if Pablo should have made himself, these pictures are out there for everyone to enjoy. So this is not from my personal stash. So last case, 27-year-old, he's a microbiologist. He has pain and instability with daily life activities. He had a non-contact ACL in 2010. He had a BTB autograft at an outside hospital. He says he had a traumatic re-rupture 2 years later. He had a revision using soft tissue allograft. They trimmed a bit of his medial meniscus. He had an atraumatic failure 2 years later. They scoped him. They trimmed some more of his meniscus. They did a tunnel bone grafting and then sent him to a quote-unquote specialist. Interestingly, his other side also had 2 failed ACLs and was unstable. Here's what he looks like. So he's neutral aligned. He has 10 degrees of hyperextension. He has a grade 3B Lockman. He has an explosive pivot shift, some medial tenderness. He had an effusion, stable other ligaments, including prone dial test. Just to move forward here, these are his x-rays, maybe some subtle abnormalities on the medial side. Looks like he has consolidation of these tunnels. Hard to see tunnel position from here. I don't have the CTs to show you previously, but tunnels look consolidated. Patellofemoral joint looked good. Mechanical axis, neutral. Tibial slope was measured to be 15. Here's kind of, again, I moved hospitals also like Gonzalo, but here's kind of what my interpretation. The tunnels were packed and looked fine. Prior partial medial meniscectomy, I'm worried about how much meniscus was remaining. Cartilage was not a concern. So I always like to make problem lists. This is what I came up with: functional instability and painful effusions. He tore twice with those graft choices, and these are my other suspicions. So Pablo, for this patient, are you gonna, do you have enough information here to try to offer him a one-stage? I know you like to do an all-in-one thing, or is this, you know, a two-staged solution, and why?
First of all, I would like to say that fortunately, this patient had a high tibial posterior tibial slope, because the problem is when you have such a huge instability and no bony issue, because what do? Anything is gonna fail. In this case, fortunately, let's say you had this problem with the tibial slope that I would definitely address it. It's 15. You know, is literature say at about 14 or something. But even in this case, even if he had around 12 or 11, I would address it, because something else has to be done to help soft tissues. So in this case, I will I will do it stages with the first flexion osteotomy to correct the tibial slope. Just one stage, and the second stage, of course, in that surgery you can see the meniscus stereo. You didn't show the MRI, but perhaps it can be done. Okay, it can be done. ACL reconstruction, meniscal transplantation, if it is needed, and of course a lateral extraarticular tenodesis. But I will address definitely this tibial slope.
Gonzalo, anything different? Is that how you're going to approach it, or can you do this all in one, or avoid the osteotomy?
Your English is too good. You speak fast. So,
sorry.
Let me summarize a little bit. So, what is the pain this patient have? Where is coming the pain from? The medial compartment?
I think he has medial pain and effusions. He has functional instability with daily life activities. He failed both ACLs. So he has, you know, hyperlaxity, likely medial meniscus deficiency, a tibial slope of 15.
Yeah. So what does he want to do? What is his goal?
Normal daily life.
Normal daily life. So in that case, so I know we are going, because we're in a session about osteotomy. So after you gave the date of 15 degrees, that's a lot for the slope. So I guess where are we going? But if I have to be honest, I wouldn't go with that route. If he doesn't really want to go competitive sports or something really ambitious, I would go for a one-stage revision ACL using auto hamstring, even if he is hyperlax. What we do now, we break the hamstring. I know there is no data behind my break. Sorry, Alan and Seth, I know you're very scientific guys, so I'm not defending that you should do it. But the clinical results we're getting in some other groups, they are very good. So I rely in the hamstring doing that braiding, or the other option, it would be the BTB contralateral, but I'm not very big fan of touching the other knee. So I go revision, and I will really consider if there is a huge lack of medial meniscus to add that stabilization with the medial meniscus transplant, if that's lacking like more than 70%, and I will increase my stability with the lemur.
Gonzalo,
25 lemurs. So, but the other option, I completely agree. If you went through the route for correcting the tibial slope, I do agree that that's something that we should pay attention in these cases.
But Gonzalo, after two ACL reconstruction failures, you still will go, just forget about, they are talking about osteotomy. You still will go just for soft tissue surgery here with such instability. I'm really much confident that it will fail.
Yeah, he said the first failure was traumatic with the BTB, which to me is the most stable graft. The second thing, high tibial osteotomy, that osteotomy is risky, the one to correct the slope, and he is not pretending to do anything crazy in his future life. And I have a lot of, well, not a lot, but I have many patients that I operate the third time ACL, and they did well, even came back to sports. So I must be honest, and that would be my approach.
Can you get a medial meniscus transplant at your first surgery? You're able to just order that, or do you have doubts whether there's meniscus intact, or repairable, or diminished?
There's an issue here because he has effusion. That means that probably it's a cartilage problem going on, because if he's doing normal life, he has effusion, or either he's having instability issues with normal life, which can happen. But I think probably the medial compartment is affected because of the medial meniscus lack. So if I will have to check carefully the MRI. I don't know if you saw it. Did you?
No, unfortunately.
Oh,
from the MRI, I thought that there was going to be little meniscus left posteriorly. Al, what do you think, bud?
Yeah, you're talking about hyperlaxity there, Seth. How much hyperextension does he have?
10 degrees only.
Only?
I mean, that's a lot. For these cases, I'd rather him not have that.
So then you're running. So I mean, I would agree with Pablo. My first thought is correcting slope, and when you've got a 15-degree slope and you want to get down to something which is in a reasonable level, 7 to 9 degrees, you're talking about, something along the lines of six plus degrees of slope correction, and you've already got a 10-degree hyperextension. That makes me very nervous, and I know de Jure has said that you can do it and you can lock them out in an extension and let them scar up the back. But I think that makes me nervous. So I would probably err on the side of not doing the osteotomy in those scenarios. In which case, then I'd be looking at a meniscus transplant. First thing I would do is get a CT scan, look at tunnels. Really want to understand what's going on with his previous and whether or not we need to do a single or two-stage. If the tunnels are good,
tunnels are good.
In which case then I'd be happy going with a single stage with a meniscus graft plus a lemur.
But the tunnels have been bone grafted, no? You said?
Yeah, they bone grafted already. You'd be able to get that meniscus right off the bat if you thought it was deficient, or you wouldn't have to scope first.
Yep.
Yeah. No, I think those are all, very valid points. For me, I kind of went with, trying to understand a little bit better, making sure those tunnels were consolidated, making sure, that I can see if there was meniscus deficiency or not, how the cartilage looked, and then combining the diagnostic scope with an osteotomy. He did have the explosive pivot shift and the 3B Lockman. Cartilage was okay. I mean, not perfect after all these surgeries, but no focal large defects. Meniscus, that's the only part of his medial meniscus remaining. The back was completely deficient. His tunnels, they actually did a good job grafting, so I had a nice clean template to move forward with. Here's kind of the technique I did on this particular one, kind of from Philippe Neret and talking to Aaron Critch at Mayo. I had some experience with this. This one I left the tubercle on. I think as I do, or if I do more of these, taking the tubercle off, maybe more facile. And so basically looking from 15, trying to get down to about 7. I don't want to go lower than 5. And so you can kind of template out, 1.6 or so millimeters to a degree. So you basically take out your appropriate sized wedge to get down to 6 or 7. Again, using those laminar spreaders in the front, closing it down. This is a closing wedge osteotomy. Fixation is less of an issue, so smaller plates can be reasonable, or staples, or cheap, whatever cheap implants you want to use. He wound up, and another thing, osteotomy, I was hopeful, Gonzalo, that I could avoid having to do repeat revision ACL meniscus transplant, maybe cartilage, and that an osteotomy alone, he'd be happy and stable. So again, trying to solve his problem in a lower demand person with a one-stop shop. So it wasn't a knee jerk that I was going back in him. So to your thoughts, I think just a little different slant on them. But he actually, while he did Al, to your point, I kept him in about 5 degrees of, short of full extension. You are always worried about that recurvatum, and yes, starting at 10 worries you more. But he did not have any more hyperextension. If anything, he probably stayed about the same or lost a little bit over time. But he still had complaints of daily functional instability. And so we did wind up going back in. And so at this point, just very briefly, it ended up, what graft is everybody using for the revision here? Just go down the line.
I use autograft. In this case, definitely I would do autograft. Same than the Gonzalo. If you have nothing to harvest from the ipsilateral side, I will go to the contralateral side. BTB,
okay, so hamstring autograft or contralateral BTB. Al, what are you using?
BTB or quad.
BTB or quad. Mm-hmm. And is everybody adding a lateral extra-articular in this case?
100%.
Yeah, 100%. Okay. So yeah, I came back, quad autograft, medial meniscus transplant, lateral extra-articular tenodesis. I wind up using suspensory fixation, took out the hardware. 2.5 years out, he has no pain, no fusion, still has good range of motion, 1A Lockman, negative pivot shift. Interestingly, he was not jumping forward to getting the other side done. It didn't have as much pain or fusion to start, so maybe that was driving the bus, not the instability and not a desire to go to higher level sport. So we were just talking about maybe doing that when I left Missouri. While it looks good and he felt good and healed well, is this the right choice, and was it the perfect option? I have my doubts. Here's kind of what it looks like. His slope was 7, so again, not overcorrecting, and neutral alignment mechanical axis. These are challenging cases, obviously, and different ways to go about them, I think, is our key take-home point from the last couple of cases.
Okay, excellent. Very well. So pretty much similar to what I had done. But again, I mean, this is something that is, we are here for expert surgeons and giving different approach. This is an issue of this multiple ACL failures in a patient, which is sometimes very trouble for me. You don't know what to do. As you have shown, you perform everything you had to do, and still the patient has this kind of laxity because it's inherent to this patient. We have no very good solution in those cases, and I think helping out with this.
Any role in a first-time revision to fixing slope, or in a primary ACL to address a very high slope, or should we dance around that risk factor and maybe do other things, extra-articular or otherwise?
Yeah, I think the key thing that you said there is that it's a risk factor, right? And the patients don't present to your clinic complaining of a high tibial slope. So you're really trying to address a risk factor, and you've got to be very careful. In the primary, I've never done it in the primary, and I don't think it's a way to go. In the first revision, if you really have a significant slope, then I think it's something worth considering. But my experience of doing slope reducing osteotomies is that I don't think I've ever had a patient who have, after doing the first stage of the slope change, their symptoms have gone away. Right? It's different than a patient who presents with hyperextension recurvatum with a flat slope, and by increasing the slope, they'll often get rid of their symptoms and then they're happy. So you're really addressing a risk factor, and therefore I think you still got to do the ACL reconstruction and possibly address the meniscus. And you know, there's no question that it's not without morbidity. And I think you got to be careful. And I think you got a great result with that one. And you've obviously made sure that you didn't dial in too much hyperextension. So, you know, it's these are tough cases, and again, there's not necessarily always a right answer in terms of how you should address these things.
Yeah, for me, this is mostly a repeat revision thing at present, except if there's maybe a varus, you know, and a slope, so you can dial in a biplanar because you have to do something medial. Gonzalo, any final thoughts?
Oh, I think it was a great solution for this case. To me, it's not the first or the second option, and I have to be sure that everything else was well done and it failed with no reason, just the slope. But I really agree with the concept, and actually, we all probably use it when we have those cases with mild instability, varus knee, with pain. We compensate with the slope. We reduce the slope to reduce the instability in those cases that we combine. When we have ACL instability and varus knee, many times, if they are not expecting like a high level activity, I'm just doing the osteotomy. I'm just modifying the slope, and that's enough many times. So you don't have to do the ACL release.
Mm-hmm.
Okay, I think we are over an hour and a half of this webinar. I think it was really, really nice. Very tough cases, really complex cases. We can see, you know, we are experienced surgeons and still different ideas from each side. Some of them are shared, some of them are not, which means that there is no a single solution for complex cases. And I just really want to thank you for joining this webinar, Seth, Gonzalo, and Al. It's been an honor to have you here, and I hope we can repeat it in the future and see how these patients are going. Why not?
Thanks, Pablo.
Thanks.
Thank you so much.
Stay safe, everybody.
Thanks.
Bye-bye, everyone. Thank you for
Stay well.
joining.
Bye now.
Bye.